Good morning. My name is Shuli Girovich. I work for HCIP and lead the research and methodology development here. Thank you so much for coming. This is our first TCOC work group meeting, and we have a lot of people around the table, but also we have a few who are participating on the webinar. So just to start with the rules, please speak to the microphone. If you press the button, push button once, it will turn green. That means on. And you can leave it on if you like. Otherwise, please get closer to the microphone so they can hear you. So we'll start with introductions, and then we'll go over the agenda, and we have a few slides to start the discussion going, but this is kind of for us to set the level a little bit and think about our work group and the charge and the important work ahead of us in terms of the total cost models that we're going to work collectively. All right, with that, I'm going to go that way.
Gary Schmidt from HCRC, John Colmers from Johns Hopkins and HCRC. Harrison Levy. Paul Miller representing Lifespan Network.
Linda Bartniska from the Maryland Healthcare Commission.
Orly Panich, I'm an emergency physician with USACS.
Mike Robbins with the Maryland Hospital Association.
Bruce Ritchie with Peninsula Regional Medical Center.
Armandale, HCRC. Kristen Polio, Adventist Healthcare.
Colleen Chiradini, Maryland Primary Care Physician.
Justin Dybel, Mercy Medical Center.
Gail Miller, HMA.
Stu Gutterman, Academy Health. Eric Lindeman, HSCRC.
Trisha Rade, Medicaid.
Donna Kenzer, HSCRC.
We have a few work group members on the phone that I will unmute right
now. All right, you're
Dan Dorn from the Dan Dorn from the Urban Institute.
Morning, Dan.
This is Joe Ross from Meredith Medical Center in Hagerstown.
Morning, Joe.
All right, so the reason we have it so early in the morning was to, believe it or not, to encourage the attendance so we can discuss the timing of the meeting at the end of the our meeting. But so I wanted to go over first the draft work plan real quick so we can kind of think about our charge and our plan. So we drafted only 3 initial meetings. As we discuss more and more, this is going to fill out, but our expectation is to meet once a month and review the work that the staff and the contractors will be doing based on your input and start methodologically thinking about all the total cost models that we need to develop in the state. So in the first meeting, we are going to have a few slides to discuss the progression model and care redesign models, and then really dig into what the total cost models that we will initially take focus on. And I see, Alicia, would you like to introduce yourself as well? So, Donna, do you have any initial comments?
I don't have any special initial comments other than we really have a lot of work ahead of us, and this is certainly one of the most important pieces of work to set the foundation for how we're going to think about total cost of care and how we're going to divide that up, if you will, around the state and have providers jointly and individually focusing on cost as well as outcomes and quality improvements for our patients and consumers.
Thanks. So to get started, I know everyone already knows this, but I thought I will start with the general. I think this needs to be on. I can't move my slides. Thank you. All right. So, we are all familiar with the model, but just to set the stage and think about the importance of the work, our new model that started in 2014 is really covering all Maryland residents, which is about 6 million people, and 800,000 of them are Medicare beneficiaries. Although initial program was set on 5-year agreement, thinking about the hospital trend, the intention really was this would be the start of the transformation in Maryland and move towards the estimates around total cost and think about how the system is going to link to create a patient-centered approach. The initial parameters of the model, as you know, is to set the hospital growth rate to the long-term economic trend, which was set at 3.58%, and underneath to provide savings to the Medicare from the national trend. So the model is not only a cost containment model, as you know, it's about also improving quality and patient experience. So with that, the model also has statewide targets on readmissions, hospital-acquired conditions, and also about 50 different quality measures that the state and the federal government is monitoring. The HCIP, as the state agency, took the initiative to implement the model, and with this transition, we went through a period of rapid change our pay-for-performance programs, and as you know, change the way the hospitals are getting paid. So it is a little unbelievable. We are already 3 years into the new model, and we accomplished a lot in that first 3 years. Right now we have 95%, and I think it's now more than 95% of revenues are under global budgets. And as we started, if you remember, those of you who were around the table, our intention was population-based model. So when we started this, we didn't even spell out what the global budget would look like. So with the leadership from the HCRC and the hospitals, our implementation really exceeded our expectations at the beginning. We're also working hard on not only changing the payment system, but changing the delivery systems in collaboration with the payers and community providers. And we spend a lot of resources already in IT and care coordination activities and thinking strategically about what makes sense to do collaboratively and what makes sense to leave the innovation to the providers and regional partnerships. With that, as you can see, we expanded our stakeholder engagement. Usually when we had the Workgroup, the HCRC really focused on hospital payments. As we are thinking about broader systems, our stakeholder engagement strategy also expanded to ensure that all the relevant parties have a seat around the table, especially the consumers. Active engagements become important in this new world. In the first 3 years, as you know, we really maintained the all-payer hospital growth, and this was a time when ACA expanded and we had expansion in the Medicaid and new enrollees. And despite that, we managed to keep the hospital growth under our 3.58 limit. Our Medicare savings are on track, and we are doing this without much cost shifting to the other pays. So if you think about the transformation, as we are thinking about new forms of doing business and care coordination, you would think that the expenditures in other areas like primary service and hospice or home health is going to increase as we are recalibrating, if you will, the care transitions and think about what was best for the patient. So while we are doing it, the idea is to maintain the total cost under control and rebalance the care that patients are receiving. So we were able to manage to have savings from the hospital trend and not exceed the total cost guardrails in the state. Our quality also exceeded our expectations. As you know, we have a higher readmission rate than the national average, but we have closed the gap substantially in the first 3 years. Our complication rates declined by 40%. And more hospitals and community providers are really working to improve the care coordination resources and really focus on high need and rising need patients around the state. So this is kind of a journey. I think it was just the beginning. Even though we did all this, there's still a lot of work to be done. And as we are moving towards coordinating care and the providers around the state, we've been working on tools that will enable us to connect the providers in different settings. We're going to talk more about care redesign in 5 minutes, but really thinking strategically about what tools we need, because we have the hospitals now shifted to population-based payment, and when we had the advisory council meeting the first time, the first need that they identified was the alignment across providers. So with that in mind, with the stakeholder input, we start thinking about the care redesign programs that will enable us for the alignment strategies and really focus on what we call potentially avoidable utilization. So conceptually, the commission and the stakeholders, I think, latched on this idea of potentially avoidable utilization. So this is a utilization that could be prevented by better care coordination. So we are not talking about unnecessary utilization. We are talking about potentially avoidable utilization, really focusing ourselves on care coordination activities and improving care for the patients. So to me, it's a broader concept than what other states would consider as unnecessary utilization. In the first couple of years, we also focused on investments and creating infrastructure under global budgets. And as I said, the 2 programs that we are launching, hopefully next year, which is 20 days away, right? That they are going to give us the chance to work out the details and start that process of alignment. So I'm not going to go through detail, but I think the intention was to take the payment out of the way of the providers and have them to think about what needs to be done in terms of improving the care delivery in the state, which will rely on, obviously, a strong health information exchange. Maryland is one of the leading states in terms of the statewide health information exchange, as you are all familiar with. CRISP is leading the nation in terms of linking the information across the hospitals and providers and creating also tools that makes the information more fluid. So it's not about exchanging information from point A to point B, but they are increasingly thinking about what is that meaningful information that needs to be exchanged, helping providers to understand the reports and information included in those data streams. I already mentioned the provider alignment, and as we're thinking about the total cost, this issue is going to come up again to think about what are the needs of different providers and how we can ensure that they're all linked towards the same goal. So we are between year 3 and 4. So as I mentioned, in the first year, we really took our population-based concept and then worked with hospitals to implement it at the hospital setting with an eye towards year 3 and 4 for alignment. In addition to the hospital payments, we are also looking at other regulatory infrastructure needs as a state, and this also opened up I would say, a better collaboration with the department. As you know, the department is leading population health strategy and some other strategies that as a state, I think I appreciate the input and collaborative work that we are doing with the department, and some of them are already in the audience and some of them are around the table, to really think strategically as a state where we need to go. I'm sure you all read the progression plan, so I don't have to go into detail, but if you haven't, I encourage you to read it in detail. As a broad, it's a dense and very important document for us. what the strategy is really to think about different accountability structures in the state and enable multiple options and multiple strategies. As you know, we have very diverse state, even though we have very small geography. And I think the strategic decision was made with the input from most of you around the table, through advisory council and through public comment, not to lock us into a single model, right? If you think about the Vermont, who is doing all-payer ACO model, it's one model. Vermont, it's Vermont. Cows are coming up in all health policy discussions these days, so I encourage you to think about that. If you listen to Governor Levitt, I encourage you to listen to his wrench analogy for the health policy reform.
Which something that we saw at the Macra conference. It was about the herd and keeping the herd moving forward in healthcare transformation, and the importance of speed, but not too speedy. So that was his message. And there were cow moos in the background in the picture. As we are providing flexibility, as you know, flexibility also brings complexity. So what we have in this is kind of an easy way to think through all these models that we are either strengthening or creating. So what you have is the existing ACOs that we have in the Medicare space. Medical home we have one of the largest private initiatives in the state. But thinking about special populations like duals, and think how we could implement a policy around dual ACO, and also what we call geographic model, taking our global budget concept and moving towards more total cost, and creating incentives for geographic accountability for the providers in the state. So those are on the top are what we call accountability models, and you could think about the payment strategies. What you have down below is the care redesign initiatives and structural approaches that could be applied to all payers, and really thinking through the care redesign and what we need to do on the ground. So global budgets is one of those initiatives that will benefit all the things on the top. What we have is the care redesign amendments or primary care home initiatives that really is going to help all of the accountability models in the state, and we have to work through the linkages between HCO's geographic model and what we are building underneath. So why are we all here? I went through quickly the broader context, but all these changes are leading us towards thinking about how we are going to build a total cost concept in each model. So we are starting with our amendment care redesign models, which has specific language, and we are going to talk about it, about the total cost guardrails. So as we are aligning incentives across providers, what are the measures that we need to build to make sure that accountability is at the total cost, including all the providers, as opposed to creating provider-specific measurement on cost and quality. We also have a task to think about incentive pools. So in the initial couple meetings, we are really going to concentrate on the care redesign programs, where we need to think about, as we are doing these alignment strategies, again, there is a specific language in the model to create the incentive pools to pay for the results in those programs. So how we are going to structure that incentive pool, where the money is going to come from, and what are the parameters around those incentive pools will be a discussion that we are going to have shortly, probably in the next meeting. From there, we are really thinking and moving beyond the amendments and think about the total cost for the state and for the hospitals. So Macra happened in the summer while we are working on the amendments, and with that there came certain conditions to classify the payment models as advanced payment models, so that the physicians could claim 5% bonus if they participate.
our existing programs are not Macra eligible, although in the regulation, our global budgets are advanced payment models. So the issue is how we are going to link the Part B expenditures to our models to make them Macra eligible. If you think about the broader Macra aim, it's moving from fee-for-service to value-based purchasing, and we are there with 55 to 60% of Medicare expenditures already. So to us, this is a big opportunity to link Part B services and ensure that we could claim Macra eligibility and also at the same time achieve the alignment of the goals with the other providers. Lastly, I mentioned the geographic model. As we are thinking about this, there are opportunities for hospitals and other providers to start thinking about a certain geography where it could be in their primary service area, or it could be an area that they're going to target collectively with other providers to implement population-focused strategies rather than patient-specific strategies. So as we're thinking about population health and attribution models for ACOs, ACO attribution model is really still patient-centric, right? You have to have that relationship with the patient to implement and get results. So geographic model, at least at the start for us, is to think about a geography rather than an attributed patient, and think about all the public health investments that the hospitals and other providers are doing on a more broader perspective. I think we could have a good discussion probably in the third meeting about ACO versus geographic model to get us think through what are the advantages and disadvantages and help us get what geographic model look like. So these are all still conceptual. So, I think we want to get your input as much as possible at the beginning and come back to you with some analytical results to help us to think through how we are going to structure a population model for the initial years. So all these total cost models that we are thinking are currently Medicare specific because we have the data. We also have the guardrails that are set at the Medicare population. But as we are working through these, I think we will come back to this question again and again to think about how we are going to move this to a more applicable state with the all payer and see where the opportunities are to link with the other providers and what they are doing in the state. So with that, I'm going to start and ask if there are any initial questions, clarifications, and then we'll move more detail on the care redesign. Mike?
Yeah, just one quick question for after the meeting. If you could actually share with this group the actual language from the care redesign document regarding the total cost of care, what those requirements actually are, I think that would be helpful.
Gail, I'm sorry, Deb, you need to speak to the microphone.
The program templates will be published this week to everybody. They'll be put out on the website. The definitions in the program template remain to be very high level, and CMS recognizes that this work group is starting and that a lot more detail will be worked out by this work group.
And that's what I wanted to get at, that we had this very high-level language, so we had some flexibility within the work group on how we define that. I just thought that would be helpful for the group to see that language.
Mm-hmm. Great. Any other initial questions? All right. I think as we think about more detail, let's hear about the care redesign and the Macra a little bit to get us kind of thinking about high level, and then we'll have more questions and discussions about the work group charge at the end of the meeting. So with that. Okay. So now let's talk a little bit about the care redesign amendment and the implications of that. The care redesign, just to give you a little bit of context, started before the progression strategy was put together. So this is sort of the interim step. 2 years or approximately 2 years into the all-payer model,
there was feedback from both the Advisory Council and the HSCRC Care Coordination Groups that there were some additional remedies that are needed to be able to provide the level of care redesign and the abilities for the hospitals to work with other providers in order to continue to make progress on the all-payer model. So the state proposed a care redesign amendment to the all-payer model. And what this amendment did essentially was two major buckets. It allowed the hospitals to get approval from relief from safe harbors and from START, and asked for data for care redesign interventions. And specifically, we're talking about data at the individual level. This was about an 18-month process and ongoing, working with CMS and the stakeholder work group to get this amendment written and passed and through all of the CMS things. So what this will do is it'll give us a framework to start to create the care redesign programs with supporting payment mechanisms that will allow the hospitals to start aligning all the providers across the delivery system through hospital-based programs. So for our initial care redesign programs, it's important to remember we're talking about hospital-based programs. So for the approach for this, the amendment is just an intermediate step that we're taking before the progression strategy comes into effect to support the complex and chronic care improvement programs, efficiency, and to assist with more patient engagement. The care redesign amendment allows us to have kind of a living program that will allow for annual adjustments as we learn how to deploy inventions, as we test new models, and how we can focus on the total cost of care. So the purposes of the care redesign program are really threefold. The first was to give the state the flexibility to be able to align incentives between the hospitals and the other providers that they're working with in the care redesign program. The second and very important one was intended to give the hospitals the tools that they need to be able to succeed so that they could line up the financial incentives between the providers that are working on the initiative. And it also creates a platform in which we can build towards the next version of the Maryland all-payer model, which of course is the progression strategy. So the care amendment program has several tools in their program. So the care redesign amendment to the all-payer model, and I know all these terms start to get a little bit confusing, provide access to the following tools. By participating, the hospital is going to be able to get detailed person-centered Medicare data beyond the data that they get within the hospital to use for care coordination and care redesign. So in other words, they're getting almost all of the Medicare's claims data per patient for the patients that go to their hospital. They will be able to start looking at the Medicare total cost of care data for planning and monitoring. This gives them approvals for sharing resources for care coordination and care improvement with other providers. And it allows the hospital to share the savings with non-hospital providers. So for the complex and chronic care improvement program, we can align the community providers around the patient to help provide better care. For the hospital care improvement program, we can begin to align the providers practicing at the hospital. And then there are other programs that are still in the development and formation stage, but some of those that we've talked about are a long-term care post-acute model. And in that case, it would allow the hospitals to start to align with non-hospital providers, all through the provisions that we'll get through the care redesign amendment. So right now, there are two care redesign programs that we have worked through CMS. And there are two of them, the Hospital Care Improvement Program, which we call HCIP, and the Complex and Chronic Care Improvement, which we cleverly call CCIP. The Hospital Care Program is for the hospitals and physicians that practice at the hospital. Its aim is to improve quality and efficiency of inpatient medical and surgical services, to facilitate effective transitions of care, to enhance effective delivery of care during acute events between the hospital walls, to manage inpatient resources efficiently, and to reduce avoidable utilization with a byproduct of reduced cost per acute care event. For participating in this, the hospital will receive the comprehensive Medicare data for them to be able to use for their care interventions, and they will be able to provide financial incentives for the hospital-based physicians. Alternatively, on the other care redesign program, this one is outside of the hospital, and this is a program for complex and chronic care patients that will involve the hospitals and community providers and practitioners, and will be focused purely on the high and rising risk patients. This program strengthens the ongoing care support for the complex and the chronic needs patient, is designed to reduce avoidable hospital utilization, and will enhance the care management tools through the use of risk stratification, health risk assessments, and patient-driven care plans. The tools, again, that the hospital will receive for participating in this are the comprehensive Medicare data. The providers will have access to hospital-funded care management resources and technology. The provider will have access to bill for the Medicare chronic care management fee. Initially, these programs are designed just for the Medicare patients, although it will eventually expand to all payers. And then lastly, it allows the hospital to provide financial incentives to the community providers and the practitioners if the hospital elects to provide one. So you can see that that's a radical difference in the way the hospitals have been able to work with their partners. So the total cost of care work group, of course, which is us, has to focus on two elements of the care redesign programs rather quickly in the next couple of meetings, as Sule mentioned. The first is the total cost of care guardrails. There are medical hospital-specific total cost of guardrails that apply to both the CCIP and the HCIP. The same Medicare hospital-specific total cost of care calculation will be used for both programs. The purpose of the total cost of care guardrail is to ensure that as we're doing care redesign, we want to make sure that there's no cost shifting from one particular set of providers to another particular set of providers. Additionally, we need to be looking at the incentive pool. In the incentive pools, physician incentives in both programs are funded out of the hospital DBR budget through the savings that they achieve. So it's important to remember as we work on this, these are hospital-based programs, and the savings come from the hospital budget that they have, with the savings they've achieved in their programs. So the work group will focus for this purpose on the CCIP program only for the incentive pool. So there's a little diagram on the bottom of the slide. You can kind of see the way this is going to work. So in order for incentives to be paid, just at a very high level, incentives have to be generated by the savings made by the program, and we have to make sure that the programs did not increase the total cost of care year over year by the introduction of those programs. Mm-hmm. Sure.
Why is it that we're only focused on the CCIP for the incentive pool?
Because the incentive pool has already been clearly redefined for the inpatient program, the HCIP. That's a program that came with a lot of data and a methodology that has been used quite extensively, and so we're only focusing on the CCIP. Did you want to add to that, Deb?
So, John, the HCIP is the original gain share that the Maryland Hospital Association had come up with, and it's been revised and enhanced to fit more closely into the goals of what we're doing with the amendment. But on the CCIP, which is a brand new program, as you know, there are still some things that we need to talk about with the hospitals to get it worked out. So, Joe, is there anything more that you want to add to that? Okay.
Okay, so funding the physician incentives. So the incentive pools in the care redesign programs are designed to provide the hospital care partners with financial incentives when the costs are reduced at a very high level. On the HCIP, which we're not going to be working on, the incentive pool dollars are derived from the savings that are driven by the reduced costs for the acute care events that include the efficiency of admissions, the reductions in readmissions, and reduced costs by other providers involved in the acute care event covered by the program. So our work is going to focus on the CCIP incentives pool. Now, the CCIP incentives pool is funded by savings that are going to be generated by a cohort of patients similar to those in the program. The incentive pool amount is essentially a calculation of historical PAUs in the base period minus the standardized current period cost of the PAU minus the intervention costs. Now, the intervention costs are the cost of the care management resources that are being provided to the providers in this program times the 50% variable cost. The intervention costs are those borne by the hospital providing the care management resources for the PDPs. It's important to note that even if the incentive pool is not generated, there's no penalty for the hospital providing the care management resources. They can continue to do that. So the guiding principles for care redesign,
is part of the intervention costs the CCM reimbursement from Medicare?
No, the CCM is paid by Medicare, and that's outside of the program. The guiding principles for our care redesign incentive pools is that the incentive dollars are funded out of the hospital GBR by actual savings. The pool should measure the program's impact in a fair and continuous fashion so that information can be readily transmitted to the providers for regular feedback. We need to recognize that in a lot of cases, providers don't really have vision into the total cost that they're actually part of. And so this may take some time for people to understand where the costs are being driven. And so we want to make sure everyone is able to see the data and has time to understand it and to adapt their behavior. The pool's composition should acknowledge that behavior change is contagious and that it will impact more patients than those in the program. And it should reflect the understanding that savings will result over time as the programs roll out. It's the program's intent to generate savings large enough to pay the incentive. So looking at the total cost of care context that lays on top of this, the overarching all-payer model has a statewide total cost of care guardrail. And that's tied to the national average total cost of care growth rate. And Maryland has performed very well when compared to national trends. CMS now has a priority on focusing on total cost of care. And the approval of the Care Redesign Amendment was contingent on meaningful total cost of care guardrails. Now, the total cost of care guardrails for the amendment are hospital specific. And the purpose of the total cost of guardrail is to create a local focus on the total cost of care. So it's important to understand that there are no unintended consequences result from the care redesign program, such as cost shifting. And we want to start creating a total cost of care awareness by all the providers in the programs, including the hospitals and the physicians, that this is the measurement that we're all going to be looking at as time moves on.
Could I ask one just quick question
Sure.
on that? Is there supposed to be any kind of interaction between the statewide guardrail and these individual hospital-specific total cost of care guardrails? For example, theoretically, you could have success under the hospital-specific guardrail, but on a statewide basis, you might trip the total cost of care guardrail for some reason outside the local area. There's no interaction between the two. We could still provide the rewards within the hospital-specific program or the local program, while statewide we could be tripping that guardrail, theoretically.
That's a good question. So I think that's something we need to discuss. Currently, the only stipulation on the guardrail is it has to be provider specific, right? And then we have the statewide guardrail. So what does that mean? As collectively, if we have trouble statewide, are we going to figure out how to link it to a provider-specific guardrail, even though one specific provider might have good results in total cost? So to us, we have to think through and see at what level we want to link that.
The total cost of care guardrail in TCIP and HCIP has to be met if financial incentives are going to be paid. If the total cost of care target isn't met, then incentives may be reduced or they may not be paid at all. It's important to note, though, that the total cost of care guardrails in the TCIP and HCIP don't add any financial risk to the hospitals. The main financial implication to the hospitals for the CCIP and the HCIP are the investment costs that they'll be putting into the program. The financial return is expected to reduce in PAUs and improve efficiencies. The hospital's ability to provide care management resources to PDPs in the CCIP program is not impacted by the total cost of care calculation. So if in year one the total cost of care guardrail was for some reason not met, that would not stop you from continuing to provide care management resources in the next year. Go ahead.
If we went back to the question on the incentives and how the calculation is made, and I understand we're not talking about the HCIP because there's a methodology there, but it seems like they're both driven off of PAU reductions. How do you avoid a double count or an overlap, or how do you deal with the overlap if there is one in the state?
Currently, I think we have a 50, like we said, 50% of the readmissions. If you think about the hospital-specific one for specialists, they're going to impact the readmission rates in our current period. So for those of you who are, our current potentially avoidable utilization is readmission and PQIs, which are the preventive quality indicators from ARC, or what we used to call the ambulatory sensitive conditions admission. So those are the two existing measures we have. So the primary care strategy would impact PQIs and some of the readmissions, and hospital gain sharing program is going to impact the readmissions. So we need to discuss, but currently we said 50% of the readmissions will be shared between the HCIP and the CCIP. So that's something we also need to think through, how much of that allocation should be done on the readmission trend.
So right now we tentatively split it, the readmission portion of savings 50-50 between the two programs, but it could be done a different way.
And did you say then you're assuming that the PQIs wouldn't overlap in the two programs?
Right, because the PQIs are, they're community-based measures in terms of how well the care is being, or how the care is being performed in the community. There could be some overlap, but generally the PQIs are more targeted at community-based providers.
Through the avoidance of the admission. So you're saying, like, if that admission that is a PQI had savings on the length of stay, that would stay in the HCIP program and not be allocated to the CCIP? Because I think if we have hospitalists, then there's a stronger overlap than with the specialists.
So if you think about, if you're going to use the standardized cost for the PQIs, anything that is saving under that unit cost of the PQI is staying at the HCIP program. Right, so by standardizing the cost, we are kind of fixing the cost of PQI in the base year. And we may need to update it eventually, but to us, anything that is saved within the admission is HCIP territory. Anything happening to the utilization rate under PQI is related to the primary care strategy. So before we go further, I want to acknowledge we have a few work group members in the audience. I apologize. as we are expanding our reach, we extend our cubicles to the other building, and we need to figure out what to do with the conference room as well. If you could introduce yourselves with the microphone, I appreciate it. And I promise you for next time I'll find a way to.
Chad Perman, DHMH Population Health.
And Doug Mitchell.
Yeah, and I'm Doug Mitchell. I'm CEO of Physicians Inpatient Care Specialists, which is a large private hospitalist group in Maryland.
Thank you. Thank you for being here. And we had additional members who came after the introduction, so if you don't mind introducing yourself too, I appreciate it.
Good morning. I'm Pat Zapp, Chair of Clinical Integration at Anne Arundel Medical Center. I also grew up on a dairy farm, so I guess that's what really qualifies me to be here.
Bob?
Hi, good morning. Bob Riley. I'm Chief Financial Officer for Anne Arundel Medical Center.
Dr. Ram Sarabemba with First Colony Anesthesia.
Thank you. So we're going to go into the Macra, but I just wanted to conceptually think about this guardrail concept. So before Macra, guardrails were envisioned as tripwires, right? So then the measurement around guardrail could be crude. It doesn't require a lot of risk, and it will allow hospitals to pay incentives. So if we do it that way, it's not going to be Macra eligible because it is a guardrail and there is no nominal risk, if you will, if you know the Macra language associated with it. So as we are thinking about our needs on the Macra front, another question that we need to think about is, do we have time? Should we invest more resources to make sure we maybe need to merge those things together? And as we are thinking about the guardrail, could we develop the value-based purchasing type total cost measure and use that as a guardrail? So that way we could have the guardrail question answered, we could have the Macra eligible program design implemented for global budgets, and that will get us two things with one measure. Alternatively, right now the total cost measures are conceptualized as primary service area type measure, looking at the trends and getting some saving requirements on the guardrail. We could leave it as that, and that will be relatively easier to work through in the next couple of months as opposed to more time needed for the value-based purchasing. So to us, it's kind of a strategic question that we need to think through and welcome your input on it.
If you read the progression plan, you will know that that there is a plan to have a total cost of care linkage to the hospital budget for multiple purposes. One of which is to make the hospital model Macra eligible by linking physician fees to the all-payer model. And providing an attractive way to get the doctors and the hospitals working even more closely than they are today together on the progression. But also, as we begin to work with Medicare and talking about the progression plan, we have only 3 ACOs in the state who have any downside risk whatsoever. So in terms of our presentation to Medicare of how we're going to bring accountability into focus for total cost of care, it's also an important strategy to begin that linkage to have a credible plan with Medicare, with CMS, in terms of how we're beginning to bring that together, and so the incentive level approach is a very modest or introductory approach. It's not a high risk strategy that drives linkage like an insurance company strategy or a deep ACO strategy. It's a more lightweight tie-in to total cost of care and entry-level way to focus on getting into total cost of care. So I just wanted to make the point that it's not, it is something that we have laid out in the plan to do. There are always questions about timing, but it's certainly part of the plan. It's very important to the physicians in the state, and it's also important to the plan.
Any comments from the participants on the phone? Oh, maybe they can't speak right now. Sorry, microphone.
Are the PAUs all payer or Medicare?
So maybe CCI, I think the intention for all these programs to move to an all-payer, but initially the focus is on the Medicare side.
The HCIP, I think, will be having all-payer information in it from the get-go, but we'll look back at AMS. But I think that's the plan. The HCIP, because it's the definitions of high needs really need to be a little bit more refined to use for a commercial population, and also because we already have a lot of commercial programs in play. The initial CCIP pool will be most likely Medicare, but the HCIP pool would be initially all payer. At least that's the concept that we're working with.
Donna, just a clarification on the TCIP and Macra. So are you saying that the current version as drafted for TCIP, we expect to be Macra compliant, or are we saying we need to go to another level of risk sharing to be Macra compliant?
We need the hospitals to take incentive for total cost of care management. It doesn't have to be a full risk share, but we do need them to take some responsibility into their GBR budget. And we do have an efficiency value, a hole in our value-based program for efficiency, so there's a place to include it in the value-based programs under the HSCRC. So we need to, so in terms of the advanced alternative payment model, we meet the basic requirements to do that. The problem is that the physicians aren't linked to the model. So by including incentive level, an incentive level linkage, then that really links the physician payments to the model, and we need to do that to meet the requirements to link physicians. So it's a very technical issue, but basically we have plenty of downside risk for everybody in the hospital model, so we're not looking for more downside risk, but we don't have a way to link physician expenditures to the model, and that's what allows the physicians to link for Macra, is by having either a percentage, I think we're going to get into it in a second here, but a percentage of their patients or a percentage of their revenues or Medicare's cost or their revenues have to be flowing through the model. And so that is the approach that we're thinking about to flow through.
So the guardrails doesn't have to be Macra eligible. So that's what I was trying to say. So with the timelines, if you are implementing the program January, right, we could work through a speedier methodology development to create the guardrails, which will be not Macra eligible. Or we take a little bit time to create a Macra eligible guardrails, what we call value-based purchasing, where we limit the risk on the total cost to the hospital, but there is some risk. If you think about a guardrail, what I was saying is it doesn't have to have any risk in it. And when you wrote the application, the language there is very flexible, so we have flexibility to change the methodology because there is really not much detail in there. The only stipulation is it has to be provider specific. And I'm looking at that. You need to.
when you put the value-based modifier into the hospital budget, it allows the hospital to be an advanced APM entity. And then the programs that are attached to the hospital budget become Macra eligible. I mean, that it's like basically the structure of how Macra works.
And we always have to say we do have to run that through a clearance process ultimately, but if you look at the regs that were put out, it already recognizes that there's a plan, and we're telling you that that's the plan that we've discussed with CMMI, but there's always the final process of getting a new and confusing rule set called Macra into play under a new administration. We can never be 100% sure, but we are taking forward something. We are trying to take forward something that's been discussed with the CMMI staff and has made its way into the regulation draft, or final regs, not the draft regs, but the final regs.
So then at the physician level, Adam, there's still stuff that has to be looked at that level. But the first step is to create the advanced APM entity, and that is what this will do. If, considering everything that Dawn had just said, it has to be approved. So you start at the top, and then you have these programs built under it, and then percentages of doctors and that kind of stuff. That still has to be looked at and negotiated as part of the progression plan.
So maybe, yeah, you can keep it step. Maybe this might be a good time to kind of refresh ourselves on the macro rules, so then we can go back to this question of how we are going to link the guardrails and the macratization of our model strategically. So with that, Liz and Laura is going to take us through the macro slides.
Great, thanks, Julie. And hi, everyone. My name is Liz Fasika, working here at HCIP. So we're going to do a quick overview of Macra. So Macra, or the Medicare Access and CHIP Reauthorization Act of 2015, was signed into law April of that year. Essentially, Macra affects services billed under the Medicare Physician Fee Schedule and replaces use of the Sustainable Growth Rate formula. In brief, the SGR essentially boosted payments to providers when the growth rate of spending on physician services fell short of the growth in GDP. Likewise, it cut payments to physicians when spending grew more rapidly than the GDP. Since 2003, this program was consistently generating cuts, and as an overall trend, many providers started increasing the volume of services they were provided to keep their income at a steady level. This led to arguably a focus more on volume and maybe away from quality. The Macra legislation is an attempt to move us forward and think more about value and quality-based reimbursement instead of volume. Again, part of HHS's larger strategy, they've defined two goals. The first goal is that 30% of Medicare payments will be tied to quality or value through physician participation in alternative payment models. The second component of the goal is that 85% of fee-for-service payments will be tied to quality or value, both of those by the end of 2016. HHS has also said that they really want to push the rest of the healthcare delivery system to follow in this trend towards value and quality. So they are inviting the members of the private sector to match or exceed these goals. This is a timeline that at the top you can see repeal of the SGR coinciding with existing Medicare reporting programs like the Physician Quality Reimbursement System, or PQRS. This is a pay-for-reporting system, which contrasts with the quality system. It's going to be replaced with MIPS, that's a pay-for-performance system. Likewise, previously we had meaningful use and the value-based payment modifier, and those are going to evolve to new systems under MIPS. In Macra, physicians will be able to fall into two different tracks for their Medicare physician services. MIPS is the first track. The second track is participation in advanced alternative payment models. when we talk about Macra eligibility, we are usually referring to participation in an advanced APM because of the substantial 5% bonus providers are eligible to receive for participation between 2019 and 2024. That's essentially CMS's big carrot to get more physicians moving towards a model that takes on nominal risk and rewards this value-based, quality-based care. Also, to note, the measurement period for performance in MIPS begins in 2017, but actual provider payments won't begin until 2019. Likewise, in Macra, the measurement period begins in 2017, payments starting as early as 2019. Then from there, once providers fall into one of these two tracks, if they're in MIPS, which is CMS is predicting the majority of providers in 2019, they'll receive a 0.25% update on Medicare rates in 2026. Providers participating in Track 2 or the Advanced Alternative Payment Model track will receive a 0.75% update on their rates. So again, this is just another incentive to get more providers enrolled in an Advanced Alternative Payment Model. Also now, providers will be receiving or will be at risk up to 9% by 2025 for those Medicare fee-for-service payments based on their performance in these quality measures. Providers participating in an advanced alternative payment model will still be at risk, but that will be through this advanced APM. And what?
Hi everyone, I'm Laura from HCIP. So I'm just going to walk through the details on the two different tracks in Macra. So as Liz mentioned, the first track is MIPS, which is the merit-based incentive payment system, and it's based on the traditional Medicare fee-for-service payments. And it actually takes three components that were part of the payment system previously. So PQRS, which was modifying physician payments, is now becoming quality, and quality is pay for reporting, whereas PQRS was pay for, PQRS was pay for reporting, and quality is pay for performance, so that's a switch. But a lot of the measures are the same. There is a cost performance area. However, this actually won't go into payment effect until performance year 2018, and it's just used for assessment for the first year. Advanced care information replaces the meaningful use, and this is mostly certified EHR technology. And CMS is also adding an improvement activities category, which includes things like shared decision-making, care coordination, and increasing access, which are a lot of the things we're already doing in Maryland. So they shouldn't be that hard for providers to get to that one. But as Liz mentioned, the MIPS program does put a larger percentage of the physician's Medicare fee-for-service payments at risk over time. So it's probably, people will more likely want to be in the advanced alternative payment models. And it's important to note that the advanced alternative payment models are actually a category of alternative payment models in general. And advanced APMs enable physicians and practices to earn greater rewards for taking on some risk related to their patients' outcomes. And that's really the distinction between an advanced alternative payment model and any alternative payment model, is this concept of risk. So more specifically, advanced APM entities must use the certified EHR technology, pay based on MIPS comparable quality measures, as well as bear more than nominal financial risk for losses, which is defined as 8% of the average estimated total Medicare Parts A and B, or 3% of the expected expenditures for which the APM entity is responsible for under the APM. It's also important to note that the APM, being part of an advanced alternative payment model under Macra, it doesn't actually change the way that providers are paid. They're still going to be paid as part of their advanced payment model, but it just creates an additional incentive for quality on top of that model.
I just want to clarify what an AAPM entity is versus a participant, because we were talking a minute ago about hospitals being AAPM entities. And I think of participants as being the practices. So is the entity some local governing of an AAPM?
Yeah, so that's a great question. So in my understanding of it, an entity would be like an ACO, and the participants would be the providers that participate in that ACO. So depending on how we structure our models in Maryland, our entities might be different things, depending on what model it is.
And in this case, the hospital is an entity, is an advanced alternative payment model. So that's where we've got an entity that's doing all of these things that you see up here. They have EHR technology, they're using MIP comparable quality measures, and they're taking more than nominal financial risk. And so are some ACOs.
And so as Donna had mentioned, we fit a lot of these requirements for an advanced APM in Maryland already, but it's the bottom part that we have to work on a little bit more, which is that providers need to be receiving a certain percentage of their payments through the advanced APM or see a certain percentage of their patients through an advanced APM, and this is for Medicare. And this will be increasing over time.
So, sorry, I apologize. If you think about this value-based purchasing concept, right, if you were to create a total cost measure for the hospitals, that means to take that and turn the lens towards the physicians and then look from the physician perspective who are working with these hospitals to see whatever measure we create, what percentage of revenue the participating physicians have through the global budget. So let's assume, for the sake of argument, we have one hospital in the state and we added all Part B to that one hospital, right? So then when you look at the physician perspective, if you look at the physician practice, maybe 50%, if you add all of it, it's 100% already. Once you start breaking down, depending on what we add in the total cost measure for the hospitals, we need to balance it to make sure that we cover enough Part B expenditures to make the physicians eligible. If we take the care redesign and attach it, so we created the global budget with a value-based purchasing Macra eligible, and then the way to decide, if you will, could be for the physicians is through these amendments to say if they are participating because they have to do other things, care coordination, other things, so that will be the linkage, organic linkage to qualify physicians for the advanced APM status. So if the physician is not participating in any of those programs, their eligibility may not be there just because they are, they have patients coming to that hospital. Does that make sense? Yes.
It's not that the physician has to take 8% risk or 3% risk, right?
Right.
It's the entity.
That's right.
Right. So, they're right now the hospital entities are taking enough risk for everybody in terms of because they are at risk for about 55% of the total cost of care. So that's clearly more than 8%. So there's not any shortage of responsibility already built into the Maryland model. It's got the most responsibility of any model going in the country. So I'm not sure exactly how Vermont steps in, but right now we're the most extensive responsibility model in the country.
Yes.
Yeah, just to clarify, when you get to the physician participation part, you list here that they have to have 25% of their Medicare revenue, but I think that goes to 50% in 18. So if the hospital is the entity and the physician is participating with that hospital, the only ones that would be immediately eligible are the physicians that have more than 50% of their Medicare revenue with that hospital, or they would have to participate with multiple hospitals.
I don't think that participation is based on an individual physician. I think it's based on the whole entity. So it's a fairly complicated calculation. We have to work our way through the rules, but as initially defined, they look at all of the physicians that are linked and add them all up to see if they get linked in the aggregate, and they don't necessarily measure it one physician at a time unless there's some new wrinkles, but it's more of an aggregate calculation. And we may have some things that we want to negotiate in Maryland about that, since if they're not at one place, they might be at the next place. And so by having multiple entities in the state, all in the statewide approach, there may be some negotiating room on that point, but we have to evaluate our need for it. And so, you know, if you had wanted to have the universe of physicians that participate at your hospital and take care of patients in your community eligible under Macra, because you want them all on board working with you, then we need to figure out what the footprint of the Part B costs that get attached would need to be. So that's really part of what we're all trying to think through and work through together. Does that make sense?
Just as an independent physician group representative here, this will be very interesting because we're in Central Maryland and we go to 11 different hospitals. So how would we fit into this whole calculation?
Right, and so I think you have to remind me, are you primary care? Okay. And this is complicated stuff. So are you participating in ACOs? So as we get into these discussions, there's even some additional complications with stacking rules, and so at least as the rules are currently written, ideally your physicians would be participating in a CCIP program with each hospital in the area that they work with, and they would register with those hospitals in their value-based program, and so that way each of the physicians that are referring to the hospitals would get covered through the program. You may not be participating with any risk-based ACOs because there aren't very many. So it may be quite important for you to get linked with the CCIP programs in order to get that qualification. So it is complicated, and we apologize for the complication, but we're all going to have to suffer through it a little bit together and try to make sure that we get folks engaged. But also, we really want you to be working with the hospitals to work out all of the handoffs and care coordination for the complex patients as they're coming out of the hospital and back into the community. In order for this model to work, people need to, the primary care doctors need to work with the ER doctors and the hospitalists, and everybody needs to be working together, particularly for these complex patients. And so it's really good for the patients, and then hopefully it will be good for the Macra qualification. So that's really the design that we're hoping for, and we apologize for the complexity, and we're all going to have to suffer through it together.
So I won't.
Pat has a question.
And just as a follow-up to your comment, first of all, I'm delighted that we're macrotizing the all-payer model. I just want to put that out there. But I think there's a
Is there any chance that person could speak up a bit or get a little closer to the mic?
Sure. Is that better? So here's a hazard I think I see in CCIP, and maybe you can put my mind to rest. If the design of the program is, as I recall, that the hospital looks within its walls to say, who are our high-risk patients that keep coming to us? Let's find out who their PCPs are. Let's connect with them. Let's see if we can enroll these patients in this care coordination program. Am I okay so far?
Yes.
Okay. And for the average primary care doc, which I used to be, I would say that probably 10, and that might be generous, of my patients would fit that description. And if we enrolled all 10, we'd be lucky because some patients don't consent. So I'm concerned that for the average doc, that's not 25% of their Medicare Part B payment, and it's not 20% of their Medicare patients. What am I missing?
Pat, so two things. One is, I think, in addition to high need, there's also the rising need eligibility, so it will be more than 10. And in the Macra world, then you would be looking at all the patients that are going to that hospital for the 25% eligibility. And if you think about, participation in multiple hospitals, then that will broaden the denominator for that practice.
So just to kind of put it, try to clarify it, and again, we apologize for the complexity, but it is complex. So we're focused on the high needs patients, but all of the doctor's patients may go to the hospital at some time. They may go to the emergency room. So they're going there for other things. So they're at the hospital, and there are reasons that the hospital needs to coordinate with that doctor beyond this high needs patient group. And the pool even is beyond the high needs patient group. And what we're trying to do, Pat, is to take all of the primary care fees and put the hospital put a small value-based modifier onto the hospital that incorporates all of the primary care fees, not just the ones from these patients, to say, hospital, you really need to work with your primary care doctors in your community to reduce avoidable utilization for these high needs patients, but really for all of the patients that might come to the hospital. So it's really incorporating all of the Part B costs from the primary care doctors in the hospital service area into the value-based program for the hospital so that it'll all be there. It's part of the total cost of care that the hospital is looking at and working with and teaming up with the doctors to take on the patients together. And as you know, in the plan, we have a primary care model coming along, a comprehensive primary care model coming along, and so then it becomes clearer. But we really do actually still need to create this linkage because of there's stacking rules, which again I don't want to bog you into the detail, but stacking rules about what takes precedence over something else, and in the precedence taking, the ACO takes precedence over the primary care model. So we will really need to have all of the doctors who are in ACOs participating in the CCIP program so they can be covered under Macra unless their ACO takes downside risk. And so that's a very complicated topic, and we're extremely interested in spending more time discussing it with people, but probably that'll take a few more meetings and maybe in doctor groups of explaining that.
The other option, if you will, I think we are saying value-based type of model we need to develop, right? And the other one that is some interest is a geographic model concept. So if you think about that too, if a hospital and partners take accountability over a geography, one zip code, then from the primary care perspective, the counts would be then all the patients coming from that zip code. And in that way, also, it will broaden the eligibility criteria for physicians if the geographic models take hold and then create. So as we are thinking through right now, we are exploring all these things simultaneously, and some might work depending on how, value-based purchasing is easy to say, but creating that benchmark will be a hard thing to do, and we may need to have some trade-offs in creating that measure. And as we are doing and maybe leaving out certain providers or certain scenarios, then we also need to think about this geographic concept and make sure that we are also developing that simultaneously to ensure we cover the bench. So I think we have a few slides left, so let's go through them, and this is great discussion, so we'll continue.
Yeah, I'll go fast with you. We talked about most of them already. So these are just the models that CMS has indicated are advanced alternative payment models for 2017, notably CPC Plus and Shared Savings Track 2 and 3. They're also anticipating some models are going to be advanced APMs in the future, notably ACO Track 1 Plus, which ACOs in Maryland might be interested in. And it's important to know that there was language referencing Maryland in the Macra final rule, and the final rule was released in October 2016. And the clause that's important for us is that they anticipate amendments to reopen applications to modify current APMs, such as the Maryland all-payer model in 2018. So CMS is committed to working with us and potentially reopening it for Macra eligibility. And we've spoken about this already, but in terms of macratizing the Maryland model, some of the key strategies that we have to have it qualify as an APM are the care redesign programs and the hospital global revenues incorporating non-hospital Part B costs through incentives, as we've discussed already, as well as the statewide comprehensive primary care model, which is based on the CPC Plus design and is being run out of DHMH, as well as dual eligible ACOs also out of DHMH and Medicaid. And there are also some ACOs with downside risk in Maryland. They're also a possibility. So with that, I will switch it back over to you.
So in trying to digest this, so it looks to me like what Maryland is in a position to do is to use the Macra incentive to participate in the advanced all-payer model to do what was the big challenge for the Maryland global budget system under the waiver anyway, which was to connect hospitals and physicians. So basically, you're using the incentive for physicians to participate in the hospital budget system to bring them into the fold, whereas before HCRC, which was all focused on the hospital, didn't have a real tool to do that. Is that a reasonable assessment of what's going on here?
I think if I could just jump in and answer yes, because I think the term of art that we use here is going to be incredibly important. To me, the word is to link physician payment. It's not to attach it. It's not to have it become part of. It is to link it. And so that is a bit more tenuous. It recognizes the independence of the physicians and how they operate. It is not rate setting for physicians and other payers. I think we have to be very careful about that so that the language not become a barrier to our ability to think about things. So.
And we're kind of pushing in both directions. So we're pushing a little bit with the hospitals to look beyond the walls of the hospital. At the same time, we're hopefully creating an attractive approach to get everybody focused on the same goals by using the Macra incentive to help that process along. And so it seems like a good approach to get folks pointed in the same direction in terms of improving patient care and focusing on care coordination and hopefully reducing avoidable utilization.
Donna, it seems like that Macra is fairly specific about individual physicians, their revenue base and the level of risk they're individually taking. We're going to try to get CMS to approve sort of more of that risk and that infrastructure being at the AAPM level as opposed to the individual physician level?
It already is. So the Macra definition is at the entity level. It's not at the individual physician level. So the entity has to take risk. So there are ACOs that don't require physician risk. They only have payouts, rewards. So it's not something specially concocted for Maryland. It's actually in existence for all of the models that are out there. So initially, we thought that the Macra was going to require individual physician risk, but it doesn't.
I have a bit more of an existential question, and I don't know whether now is the appropriate time to ask it or not, but I'll put it on the table. The work here seems to be focusing, again, along multiple tracks. And so the part of the track that's associated with the care redesign amendment, which has been already approved by CMMI, and there are 2 models under that are already approved, although we know there's still a lot of detail yet to be worked out, including the work that this work group is engaged in. At the same time, we're focusing our attention appropriately on the progression plan, and in particular, I'm focusing my interest on the CPC Plus model, the primary care model, which I, for one, am personally quite excited about the manner in which it's designed and its prospect. I worry about spending energy and time on the CCIP model and getting that resolved, likely not to be implemented just given mechanics, statutory requirements, work of this group to be done at the earliest, I think, in June or July of this year. And if the hope is to have a CPC Plus model up and running by January of next year, I do worry existentially about the time, level, and effort on one model versus the other that I think are in some ways attempting to address both the same problem. So again, I don't know whether this is the right forum for that or for us to discuss that, but I do think it's something we ought to contemplate, because in either event, we do have to think about again, getting back to the work here, which is around total cost of care. Are we doing work here that is different for the CCIP model from what we will need to do around the CPC Plus model?
And I think the answer is yes, we are doing something different. And the view of our staff is that we will go back and customize the CCIP so it fits exactly with the CPC Plus quality requirements, so that there's no extra work going on to link the things together. But there's clearly a need for handoffs of the highest need patients and coordination between the hospitals and the primary care doctors for the highest needs patients. And so this CCIP program is really focused on creating the relationship for those handoffs and the working together around those patients. And so it is critically important to the success of the all-payer model and ultimately to working with the primary care doctors. The other thing is that it is, unless something changes, it is also critically important to the macrodization for the doctors who are in ACOs because the ACOs are not downside entities, that the CCIP program provides them macrodization that their ACO doesn't provide. And the ACO, again, sorry for the complication, trumps the CPC Plus participation. So that's in stacking rules, the ACO is the top level of the stacking entities, and if the ACO doesn't qualify for as an advanced alternative payment entity, then even if the primary care doctor is participating in CPC Plus, they won't be engaged in a Macra eligible entity. So we want to make sure that in closing the loop on the hospital side, that we create the opportunity for them to also participate in the Macra eligible entity and do all of the important things of coordinating with the hospital and coordinating handoffs, because if you start thinking about the handoffs, I mean, now we have a community program and they're going to be having some of the same patients that go to the hospital. The hospital has transition and care management programs. They need to work together to figure out when does the patient get handed back to the practice's care management. So there is a lot of work for them to do together, and we should really focus on structuring it so that it's not extra work, it's only the work that they have to do already to make an effective program. So I know that's a long-winded answer, but I do think it is really important for us to continue working on it, and I don't believe it's duplicate work. But we can continue to discuss it and think about it together.
Any other comments on the phone or in the audience? So I guess then going back to the work group, I guess we could spend a few minutes in terms of our expectations. We are gearing up our school work to explore some options around total cost measures. You could go about thinking about episodes, right? Or you could think about primary service area. So by January, we're hoping that will give you a sense of our total cost trends. And if you look at from the episode perspective, what percent of total cost we are capturing versus if you do a primary service area, what it looks like at the very high level. So we are going to dive in deep into some of the technical issues and back and forth strategic question and some data-driven approaches to alternatives. With that, Donna, do you want to?
So I think we'll be trying to answer your question about how you get 50% in, and we're going to be modeling away at that, trying to make sure that we understand how that might happen or not happen and what we need to do on that front. And I guess I think several folks in the state have really asked about more discussion on how things fit together. How does CCIP fit with the CPC Plus and the ACOs that are working hard in the state? And so I think, I guess we'd like to hear from you all. What should we be focusing on to help along the understanding process with the complexity that's here? Should we have some separate discussions on these concepts to continue to explain and dive into them some more, or what's your advice?
Donna, this is Joe Ross. As I'm listening and thinking about this, I keep coming back to the very practical matter of how do they link, and how might a community or a group of organizations come together around the models. And I thought that the work done in the primary care model with the scenarios showing the various described entities and how they might interrelate. I was struck listening today how we might benefit from taking the time to take some of these concepts and try to graft them into examples of a Macra compliant, total cost of care focused model. You know, one might include an ACO in it, one might not, and kind of begin to build those out. So in practical terms, we have tools to communicate with stakeholders around and I think it might help to, I don't think we can make it less complex, but maybe visualizing the linked models might advance the conversation.
Okay, thank you for that suggestion, and we'll focus on doing that. We have been working on a memorandum to describe the ACO issue, but I think some visuals could be helpful too. Other comments or requests as we start to prepare for the upcoming meeting?
Back to your earlier suggestion about having perhaps an offline conversation about how primary care, what they view their challenges are right now in trying to sort through. They may be in an ACO, yet that ACO may have, because of the upcoming possibility of Track 1 Plus for 17, they have a MIP plan that, look at all of this from, for example, an independent primary care group. We would love to sit down and talk about it.
Okay.
I think one of the, if I understand this correctly, we're going to need some of the fee-for-service payments to be running through not rate regulation, but it's going to be kind of unfamiliar territory. There's going to need to be a certain amount of what would normally be fee-for-service payments. If I'm understanding this correctly, 20% is running through this entity in some way or is somehow linked to this entity, and that might have to increase in the future. So that, I mean, to John's point, how that's done and how that's structured is going to be, I think, one of the areas where I think the provider community is going to be very, very focused on and how that's linked. Is there any ideas on how that linkage would occur? You said there would be paid as incentive payments potentially or value-based payments. So is it basically like a flow through that all those payments would be made, but they would just be made in a different way based on some value metrics that are set up, or how has there been some thought into that? Because I think that's going to be something, it has to be done very carefully, I think, so that it doesn't seem like it's becoming a rate setting sort of.
Right. So an ACO, we're talking about a similar concept to an ACO. So I think what you're pointing out is we need to get that slide deck so that we don't get people thinking that we're trying to do rate setting for doctors, because we're not. An ACO, your fees flow through an ACO for the patients that are attributed to the ACO. So any patient that if you're participating in an ACO, your fees for your anesthesia flow through that ACO for those patients. So what we're and so that may qualify you for participating in an advanced alternative payment model if that ACO takes downside risk. So what we're now trying to do is a similar concept. So we're not trying to change the way physicians are paid by Medicare. We're trying to flow through their payments in a similar concept as an ACO, so that it's not changing the physician payment mechanism, but it's getting attached to the entity. In this case, the entity for the all-payer model is a hospital. But so it's really the same concept as an ACO. It doesn't have any implications for physician payment, except if you're participating in the hospital and they decide to have an incentive program, then you may get incentives from the hospital, but it's not actually having any impact on your Part B payments from Medicare.
So to be clear, your payments actually don't flow through the ACO. Your payments go to you, and they are attributed through the ACO for calculation for gain sharing. So again, I think language here is really, really important. I think the analogy to an ACO is the right one, but it doesn't flow through, because that, at least the way I heard that, Donna, was that the payment comes from Medicare, goes through the ACO, and then goes.
Right, and that's so you're right. It's the same mechanism as an ACO, so it's not really flowing through the ACO. It's being attributed. So in this case, we're attributing it to a hospital, and it becomes part of a value-based payment program that the hospital is participating in. And so it's not a flow-through, it is an attribution.
So if you think about the episode concept just for a minute, right? Right now we have global budgets on the hospital, Part A, right? And then let's say we create a total cost measure looking at the 90-day episode, right? So that will create a total cost measure for the hospital. And similar to our readmission program and other programs, we could create payment adjustments around how hospitals are performing on a total cost for that 90-day period. So that makes the global budget eligible for Macra, depending on the CMMI and other things. And then any physician who is engaged with the hospitals through amendment programs would be linked and eligible for advanced APM participation through that concept. So to us, then the physician is still getting paid regularly, but the entity global budget becomes Macra eligible. And then as we define the relationship between physician and the hospital, that will enable physician to claim advanced APM.
But there is no bundling of fees.
Right.
There is no bundling of fees in the process.
Right.
And to be clear, just to be, because I don't think this point was made around the 5%, is that does not count against the total cost of care. At least the preliminary indication from CMS is that does not count against our total cost of care guardrail. And
it's actually written into the law. It's not even an indication. The law was written to say that the federal government, it was written into the law that the 5% doesn't count against total cost of care. I don't think they wanted that to stand in the way of if the first thing that you face is that you have to pay your own 5% bonus out of your risk pool. I think they wanted to stop that from being an initial barrier for doctors to get involved in APM. So they did pass that in the initial legislation to say it did not count against total cost of care.
So a question. If the hospital is in fact the entity that is at risk, are the individual participants, the physician groups or however, are they each uniquely responsible for the 25%, or it's the entire entity? So it would actually be the hospital itself that it meets the threshold, not each participant itself.
My understanding is that you're talking about having their fees attributed, let's use that word instead of included, attributed to the entity. My understanding is that it's all of the participants that are linked, all measured together.
So aggregated all together. Yeah, so that actually makes, it would seem that, for a lot of, it's as an emergency physician, 100% of my patients are in the hospital all at the same time, and it's easy for me to reach that threshold. But for people who, anesthesiologists who have practices outside and primary care, you benefit from the fact that the entire entity, in fact, it contributes. So I think that's actually a very big plus.
Right, and then there's just a ridiculous number of other issues to tackle too, like keeping NPIs and TINs discrete so that you don't load up a bunch of physicians who aren't actually in the service area of the hospital, thereby screwing up the 50% qualification. So there's a lot of hurdles to jump through, and so we're going to have to jump through them together. I mean, we were sitting at the conference, and so they were talking about the doctors group that had 1,500 doctors all under one TIN, and so and they were practicing across the whole state, and so making sure that as they worked with so if they were all in an ACO, for one ACO, for example, they probably would ruin the chances of that ACO ever qualifying as doctors because there's too many of them all together. So it starts getting complicated, but we'll weave our way through this together. So you can't do it with one hospital and put them all in. It's going to have to split them up, Doug. Oh, okay. So you've got them split up already. But they don't have to be split into separate TINs. There's actually just the way they get registered. So we'll have to work through that pain together.
Okay, thank you so much. I think this was a great first meeting. We appreciate all you being here and looking forward to the next one.